concepts of angiogenesis and vasculogenesis will help you to understand some of the complications that you may encounter, will help you to understand arteriovenous malformations and other vascular shunts in a deeper way than just like your normal Rosler-Rubinstein classification of vascular malformations. So if you are able to stay awake during this lecture, that's actually the first test for you here. You will be able to survive the rest of the course. So this will be our overview. We'll start off with a couple of definitions. What is vasculogenesis? Vasculogenesis happens only once in your lifetime, and this is at the beginning where from avascular tissue we will have constitution of new endothelial tubes, de novo, and therefore we will begin to have new blood vessels. And following vasculogenesis, which is again only happening once in utero, you'll have a process that is called angiogenesis. And angiogenesis means the formation of new blood vessels from pre-existing ones. So vasculogenesis, there are no pre-existing ones, and angiogenesis is then kind of a remodeling and sprouting and new blood vessels that are coming from already pre-existing ones. When we are looking back at the in utero, then it is that endothelial cells differentiate within a primary avascular tissue. They then start to coalesce, form a tubular network, which will then constitute the aorta, major veins, and plexus in between, which will form the capillary bed later on. During the next processes, i.e. during angiogenesis, we have a remodeling where this network is modified, where certain vessels are no longer used, they can be pruned, and certain vessels need to be larger and sprout into now new avascular tissue as the embryo matures and grows. The angiogenic sprouting means that from a pre-existing vessel, new vessels form that sprout or grow into avascular tissue. And this necessitates a destabilization process, i.e. the primary vessel that now needs to grow into a new vessel has to get into a more destabilized form to be able to do so. And these types of maturation processes and the angiogenesis is mediated by various growth factors that we'll need to discuss. There are three main families of growth factor. There's the VEGF family, the vascular endothelial growth factor. There's the angiopoietin family, which means that there's not only one angiopoietin but multiple. There's the efferent family, and all of these work on the endothelium. And then there are those vascular growth factors that are non-endothelial cell related, i.e. that are related to the surroundings of the blood vessels, and these are TGF-beta and PGF dependent. And of course, all of these different growth factors have to work together in a coordinated manner to form stable blood vessels. What is VEGF? It's the most critical driver of vascular formation. It's the vascular endothelial growth factor. If you have animals that have no VEGF, they are not viable because they don't have any blood vessels. VEGF initiates the formation of cells to become to sprout into new or avascular tissue, and it is regulated by the oxygen tension of tissue, which is regulated through hypoxia-inducible factor. It's actually quite simple. If you are in avascular tissue, then in this avascular tissue you don't have enough oxygen. That means HIF will be upregulated, and if HIF is upregulated, VEGF will be upregulated, which means that you will have a directed sprouting into the hypoxemic tissue of new blood vessels. If you only give VEGF without the other growth factors, especially without the angiopoietin, you will have leaky, immature, and unstable vessels. We will talk more about this when we are, for example, talking about the angry red vessels surrounding a brain AVM that you as neurosurgeons may know, that are kind of these leaky, immature, and unstable vessels that are quite brittle and that like to bleed easily. If you don't have VEGF, or if you don't have the receptor, here VEGF receptor 2, then you have very few endothelial cells, and obviously these mice cannot survive. A very good example of VEGF regulation is can be seen with the retinal vascularization. Primarily, if you have initially a vascular retina, you will get angiogenic sprouting into this retina. However, if you now put the rodent under hypoxia, i.e. under a lot of oxygen, then the retina will not have HIF, will therefore not have VEGF, and it will therefore remain avascular. And when then the animal is returned to normoxia, the undervascularized retina will be hypoxic. This will lead to an overshooting response of VEGF, and then you will have these leaky vessels sprouting into the retina, and then you will have blindness. And where does this happen? This happens obviously in immature babies that are in an incubator, where there's a lot of oxygen tension, and a high risk for these immature babies is to become blind, because exactly this will be happening when the babies are returned to normoxia. The now undervascularized retina will become hypoxic, and then you will get bleeding into the retina from returning the child into normoxia. Now this is VEGF. What about the angiopoietins? The angiopoietins act on the so-called Ti receptor, which is only found on the endothelium, and there are two different types of angiopoietin, 1 and 2, and these have various roles. Angiopoietin 1 can be best described as being the stabilizer of the blood vessel. Angiopoietin 1 will allow to have support cell associated to the endothelium to make stable blood vessels. If you don't have angiopoietin 1 or this receptor, you will have normal vasculature to begin with, because this is mediated by VEGF, but then due to the lack of the maturing of the cells, they will still be kind of leaky vessels as if you had only given VEGF itself. On the other hand, if you overexpress angiopoietin 1, then you will have an increase in vessel size, but not in vessel number. Remember, the vessel number is mediated by VEGF, and these vessels would be very resistant to leakage. As I said, angiopoietin 1 is the stabilizer, but we also need a destabilizer. Remember, in order for the blood vessels to go towards an angiogenic sprouting, they have to get into a more destabilized form. They have to be able to kind of get less mature to be able to sprout into avascular tissue. So angiopoietin 2 therefore allows the endothelial cells to revert to a more plastic state that will then lead to either regression of the vessel if there's no VEGF, because not all of the blood vessels are needed, or it will lead to the formation of new vessels in the presence of VEGF. And therefore angiopoietin is not only important for the initiation of angiogenic sprouting, but also for a process that we call pruning, where those blood vessels that are no longer needed kind of go away with time. So therefore, the main role of angiopoietins is blood vessel maturation, remodeling and stabilization of these vessels, and maintaining the stability of the mature vasculature. So VEGF makes blood vessels. Angiopoietins stabilizes or destabilizes them, and the ephrins give the blood vessel identity, i.e. if you have, for example, ephrin B2 on an endothelial cell, this will become an artery. If there's ephrin B4 on the endothelium, this will become a vein. So therefore, the ephrins are involved in establishing arterial versus venous identity in the initial primordial vessels. But it's also interesting that these ephrins have other interactions. For example, they are important for the endothelial cells to interact with the smooth muscle cells, and they are also important for the guidance of axons and therefore of central nervous system development. And for those of you who are diagnostic neuroradiologists and who are interested in, for example, epilepsy imaging, you all know that certain focal cortical dysplasias can be associated with developmental venous anomalies. So when you have a DVA, always look for associated cortical dysplasia, and the problem there is a problem of the FRND4 receptor that is both involved in the development of the central nervous system and in the guidance. And we have recently identified that there's a link between, for example, polymicrogyria and brain AVMs. And this link is again mediated through an abnormality in the effrin before identity that can cause both a problem of lamination, which is the initial problem of the polymicrogyria, and it can cause a problem of a brain arteriovenous malformation. So we talked about the growth factors and their roles, we talked about the definition. Now let's dig a little bit deeper into the primary development of vessels in utero, i.e. the vasculogenesis. In vasculogenesis, we'll have this primary or primordial vasculature that is being built between arteries and veins. And these endothelial cells differentiate within the primary avascular tissue, then coalesce and form a tubular network to combine the initial arteries and the initial veins. This happens in the mesoderm, i.e. between ectoderm and endoderm, and closer to the endoderm as the ectoderm is actually inhibiting the growth of those primordial vascular cells. When we are looking here at our vasculogenic mesoderm between ectoderm here and endoderm here, some cells start to segregate and migrate towards the endoderm. These cells form primary vascular cords that will then coalesce and differentiate into endothelial cells that will then form the primary vascular network as well as the blood cells. So the progenitor cells for both the endothelial cells and the blood cells are the vascular cords right here that coalesce close to the endoderm. The vasculogenic mesoderm surrounds, as you can see here, the mesoderm, and it's promoted by VEGF and it's inhibited by ectoderm, which is why this is where the primary vessels form. And this is mediated by, again, HIF, hypoxia-inducible factor, that will activate VEGF. As I said, arteries and veins have different types of receptors and can therefore be identified as molecularly distinct vascular structures. The next thing that is of importance is when you are looking at the origins of arteries and veins in the brain as compared to the rest of the body. In the body in general, all of the endothelial cells, the pericytes, smooth muscle, and connective cells come and arise from the mesoderm. But for the brain, head and neck and face, it's different. In the neck and face, and therefore in the central nervous system, the pericytes, smooth muscle, connective cells are actually arrived from the neural crest, whereas the endothelial cells are only derived from the mesoderm. And this is just one of the reasons why you cannot, for example, say, oh, this stent worked very well in the vessel of the heart or in my popliteal artery, so I can put the same stent with the same type of reaction into my brain cells, because our cells in the central nervous system, our vessels in the central nervous system, are having a completely different setup and a completely different phylogenetic origin as compared to the blood vessels elsewhere in the body, which may mean that they will react differently to various materials that we may put in. Okay, now what about angiogenesis? Angiogenesis as compared to vasculogenesis is that we have a remodeling process. The primitive initial network that was built during vasculogenesis is now modified. Some vessels are pruned that are no longer needed, some vessels are growing, and therefore you have a remodeled vasculature, and this angiogenic remodeling will need to undergo first a destabilization process mediated by angiopoietin 2, and then if you have VEGF present, then the vessel will get larger. If there's no VEGF present, the vessel will kind of remove itself. And this pruning or vessel enlargement can be best seen when we are looking at the embryonic aortic arches that form and remodel around the pharyngeal endoderm. And you will hear later from Insub how these different arteries of the pharyngeal arteries will be pruned, will remove themselves, or will enlarge during the further embryological development. So therefore, if you are summarizing this concept of cephalic vessel formation, in the moment where you have low oxygen tension in your tissue, HIF1 is activated, this will lead to the increase of VEGF. This will lead to the formation of the aortic arch cage around the pharyngeal endoderm, and then you will have ingression of neural crest cells into the endodermal cells that come, into the mesodermal cells that form the endothelial cells, and therefore kind of both cells have to coalesce, or both groups of cells have to coalesce to form the mature head and neck cells. And this is therefore also explaining why for the head and neck and face region, the vascular remodeling and vascular formation is associated also to the formation of, for example, the bones and the facial structures, because they are also rising from the neural crest. The embryonic angiogenesis has to be now compared to the postnatal angiogenesis. As we are speaking, as you are sitting here, your blood cells are not just like the same that they were like 7 or 10 years ago. They are constantly remodeling. Each cell in our body is remodeling in time. Some have a large turnover, some have a shorter turnover. And our blood vessels in the brain have a turnover of somewhere in the range of 5 to 7 years, which means that the blood vessels that you have right now in your brain will be completely different from the ones that you will have in 7 years from now. Let's talk a little bit more about this angiogenic sprouting. Let's say we have a stable, mature vessel here, but the body is growing. When the body is growing, it has to go through a destabilization process. The unstable vessel will either regress if there's no VEGF present, or it will develop new sprouts if there's VEGF present. And the way that this is working is that through angiopoietin 2, the outer neural elements are diluted. You will have an activation of the endothelial cells, directional sprouting directed by the VEGF gradient, and once the sprouts has formed, they will be recovered with parasites. We will have mediated through angiopoietin 1 a stabilization of the endothelial cells and the reconstitution of the vessel wall. And the growth factors that are present in postnatal angiogenesis are the same types of growth factors that are present during embryonal angiogenesis, and therefore we have to familiarize ourselves with VEGF and angiopoietin, especially when it comes to abnormal postnatal angiogenesis, when we are talking about tumor angiogenesis. A couple of peculiarities of the endothelial cells: they rarely divide once in 3 to 14 years, on average 7 years. But if you, for example, let's say cut yourself, or if you break a bone, then you need a blood vessel kind of right now, right immediately. And so they can be induced to replicate way faster, actually to replicate to once in every 5 days, which is quite a fast replication rate. And then, of course, we'll have to think about tumoral angiogenesis. Let's say a tumor is starting to grow. It first will start with an avascular tumor growth, but at one point in time, the tumor will become so big that the central portions of the tumor will become hypoxic because the oxygen will no longer be able to get there because of the larger or enlarging tumor. And in the moment where tumor tissue is hypoxic, HIF will be upregulated, VEGF will be upregulated, and new arteries will sprout into the tumor. And this is why, for example, in fast-growing tumors, such as the glioblastoma multiforme, avestin will work. Because what is avestin? It's a VEGF inhibitor. It inhibits, therefore, the angiogenic sprouting into the tumor. But what can also happen is that the tumor may get like its oxygen from local diffusion and continues to grow. But now that there is no longer with avestin any VEGF, you don't have leaky blood vessels, which means that if you give contrast, you will not see any contrast enhancement in the tumor despite the tumor growing. And this is the pseudo-regression that you can see in patients who are under avestin treatment. And like again, understanding these concepts of how VEGF works, what VEGF makes, i.e. leaky blood vessel cells, can help you to understand the reactions of, for example, a VEGF inhibitor. Now let's talk about the angiogenic switch. What do I mean with angiogenic switch? There's the activation phase. In the activation phase, your endothelium gets permeable, the basement membrane is degraded, new endothelial sprouts are forming, and new lumen is forming. This activation phase has to be balanced with the so-called resolution phase, where there's a stop of the endothelial cell proliferation, where your basement membranes are reconstituted and endothelial junctions are again reformed. If you only have an activation phase without a resolution phase, you will get just like blood vessels that are forming and sprouting anywhere and everywhere, and then they will start to connect with each other and form shunts. So therefore, the switch from the angiogenic, from the activation phase to the resolution phase is important to make mature vessels. And if this is defective, then abnormal arteriovenous connections can form, abnormal shunts can form. Now, the angiogenic switch is mediated by two gene products. One is called endoglin and one is called ALK1. And it so happens that if one of these are missing, you have this imbalance between activation and resolution phase, which can lead to structural abnormalities of vessels and pathological shunts. And you may know that these are the two gene products that are defective in hereditary hemorrhagic telangiectasia or morbus Rendu-Weber-Osler, which is a disease that is characterized by the formation of abnormal shunts in the body, in the lungs, the GI tract, but also in the central nervous system. So, hereditary hemorrhagic telangiectasia is an autosomal dominant trait where you have various forms. By now we have actually 4 different types of HHT. We have a mutation in the SMAC gene, as well as HHH3, and it is all related to a problem of like a disbalance of the angiogenic switch and therefore the formation of abnormal shunts. If we will talk about the relevance of this angiogenic switch now when we speak about applications of what we have learned so far about like this brief overview about what is angiogenesis and what is vasculogenesis. And we'll now go through a couple of clinical scenarios where I believe understanding vasculogenesis and angiogenesis can help you, because it will help you to get you towards a more etiological classification of brain vascular malformations. And what do I mean with this? When you look at your old textbooks, the Russell and Rubinstein classification of brain vascular malformation, when I was a resident, there were 4 different types. You have the brain AVMs, the cavernomas, the capillary telangiectasias, and the DVAs, which is for your everyday life okay, but it's kind of oversimplified as we will be able to see later on. What Pierre Lagenias proposed when he discussed about a classification of neurovascular diseases was a classification that is based on etiology and that has 3 different pillars: the target, the timing, and the trigger. The first pillar, target, is which portion of the arteriovenous-lymphatic tree is affected. Do we have an arterial disease? Do we have an arteriovenous disease? Do we have a venous disease? Or do we have a lymphatic disease? And as I told you in my talk about like the efferents that give specific identity to an artery or to a vein, you can understand that blood vessels are not simple pipes. They are actually molecularly distinct prior to angiogenesis, just after vasculogenesis. So the angioblasts that form your primary primitive vasculogenic networks will be subdifferentiated into arteries or veins, and therefore different types of vessels are different molecularly defined targets. Even if you are now looking at the differentiation of veins into like the venous blood vessels or the venolymphatic vessels, there are different receptors on those cells, on those endothelial cells, that make the identity of artery versus vein versus lymphatic system. And therefore you can now identify, if they are molecularly distinct, you can have a target or trigger that hits a specific target, either on the arterial side or on the venous side. And this is how Pierre then pointed out this arteriovenous-lymphatic tree. We have some diseases that are purely arterial, aneurysms, dissections. We have some diseases that are like on the arteriovenous transition, HHT, vein of Galen arteriovenous malformation, AVMs. We have some diseases that are purely on the venous side, dural sinus malformations, cavernomas, developmental venous anomalies. And we have venolymphatic diseases and then purely lymphatic diseases, the VVMs and the VLMs. The second pillar that Pierre proposed was the pillar of timing. When does a specific trigger hit? Is it very early on? Then the impact will be larger as compared to a very late trigger. And what he meant with this was that the cells of neural crest cells that come to try to get towards the mesodermal endothelial cells are migrating from the neural crest in a very defined and predetermined pathway. And while they are migrating along their pathways, they will seed their daughter cells along the path. If you have a defect very early on in one of these migrating cells present, it will be transmitted to all of the daughter cells along its migrating pathway and will therefore have a larger impact. What do I mean with this? Let's say we have a cell in the neural crest here, and it has not yet migrated. And some trigger has hit the cell and now made it a vulnerable cell to develop, let's say, arteriovenous malformation. It's now starting to migrate, and while it's migrating, it's seeding its cells along its predetermined pathway. And therefore, if we have a very early problem, we have a large impact as compared to a later problem that has a more focal impact. And therefore, the size, area, and severity of a defect that is produced by the primary or causative trigger will be related to the timing of the event in relation to the migration. So, make it simple, early hit will have a larger impact as compared to later hit that has a more focal impact. And now we can cross-tabulate this. We can see, okay, we have vascular diseases on the arterial level, on the arteriovenous transitional level, on the venous level, that can be very focal, or that can be, because the hit early, have way more of a larger impact. And we can fill this grid, but first let's have a look at the third pillar. The third pillar is the type of trigger. Is it a genetically induced problem, or is it an environmentally induced problem? And so, again, this is from Pierre, who said there are some diseases that are purely extrinsic, such as trauma. And there are some diseases that are purely genetic, for example, HHT. And then there are some diseases that are maybe somewhere more on the extrinsic side, like the dural arteriovenous shunt, and some diseases that are more on the genetical side. As we know, the AVMs have moved way more towards the role of the genetics side right now. And so this allows us now to put in a third dimension. And the third dimension is the genetical diseases. And we will go through all of these diseases, of course, during the course, but think about focal arterial diseases as your aneurysms or dissections. Focal arterial diseases that are genetically determined, Ehlers-Danlos, polycystic kidney disease. You can have segmental arterial diseases, we may talk about neuroaneurysms. Early arterial diseases, here we talk about phases, and I think Sirentara will have a talk about this. On the arteriovenous side, we have, of course, the AVMs, the AV fistulas, but the genetic focal arterial diseases could be HHT. Intermediate diseases could be proliferative angiopathy. The early ones, the arteriovenous metameric syndromes that we will talk more about. On the venous side, we have cavernomas, DVAs. We have familial cavernomas, where we have problems in the CRIT gene that will cause a genetic form of focal venous diseases. We have the more intermediate diseases, such as neural sinus malformation, and again, the metameric diseases as indicated here. So, the first application of what we've learned is that I believe that understanding vascular malformations from a concept of vasculogenesis will help you to give this etiological classification. And of course, these are not fixed boxes, but there's a lot. It's can be seen as a spectrum of diseases. And sometimes we have, for example, difficulties of differentiating when is it more proliferative angiopathy versus a diffuse nidus AVM. When do we go all the way towards an arteriovenous metameric syndrome? Okay, the next item that I would like to highlight is about the congenital nature of brain vascular malformation. When we are looking at these two patients, this patient has a subarachnoid with an aneurysm, this patient has a small AVM with a bleed. What do they have in common? We are seeing them at the clinical stage, where the lesion has become already clinically symptomatic. However, prior to the clinical stage is, of course, a morphological stage, where the lesion is already there, the patient has an asymptomatic aneurysm or an asymptomatic AVM. So the incidental findings can be subsummarized at this morphological stage. But I hope that what you are now understanding from the first portion of the talk is that even prior to a morphological stage, there are different other stages that you will have to go through. Let's start off. We are at the pre-pathological stage. Everything is still okay. But during a window of exposure, a cell can be made, or it can be vulnerable for a specific trigger. If this trigger hits the mother cell, and the cell does not die, we move into the genetical stage, where a primary weakness of the cell is generated and then transmitted to later generation cells. Remember the clonal distribution. If the defect is neither repaired nor does it lead to cell death, we are moving into a biological stage where the lesion is not yet visible, but it exists as a permanent weakness in a clonal distribution. So this sounds very esoteric, but let's try to make it easier. Let's say our cell is here, it has a chromosome, our primary or causative trigger hits this cell, and we are at the genetical stage. The cell starts to differentiate and multiplicate, seed the daughter cells along the predetermined pathway, and we are now having an organ with a weakness, but not yet the disease. Then a secondary or revealing trigger can hit this organ that is weaker, and we'll get to the organ with the disease, the brain with the AVM. And then it may actually then get towards the clinical or symptomatic stage later. Let's take the example of HHT. We have the mutation in the endocrine gene. This mutation in the endocrine gene will lead to the disease HHT with the propensity to develop AVMs. But not every patient with HHT has a brain AVM. Not every patient with HHT has the mucocutaneous telangiectasias. In fact, they can develop over time. Most kids with HHT don't have epistaxis. Epistaxis starts at 14 years, because this is the time where the telangiectasias in the nose start to develop. So you are having still the disease of HHT, but you're only having the propensity to develop AVMs. And then due to a secondary trigger, you will get into your asymptomatic AVM. And then we are thinking about environmental factors such as inflammatory changes within the AVM, such as high flow stress, hemodynamic changes, i.e. purely physical changes that will then lead to the ruptured AVM or the AVM that is presenting with epilepsy. Okay? As clinicians, we are seeing our patients here. As radiologists, we are seeing our patients here. And as interventionalists, we can treat the patient either here or here. But we have to understand that maybe in the future, the treatment can be at this level, or at this level, or even at the primary or causative trigger level. So therefore, are AVMs congenital? It does not mean that they are present at birth. Just as much as a vestibular schwannoma in a patient who has NF2 is not necessarily present at birth, but you're born with a propensity to develop those vestibular schwannomas. You're born with a propensity to develop an AVM. And now remember what I said regarding the turnover of blood vessels in the brain. Blood vessels turn over every 7 years on average, which means that if you have an area with a dormant but transmittable defect, it can at one point in time lead during the vascular remodeling and maturation towards a new development or an unmasking of the underlying lesion and the development of a brain AVM. In fact, for HHT, we now have a couple of families and a couple of patients where there was clearly no brain AVM before, and then after 5 years when we did the screening, we did see on follow-up imaging a brain AVM that had developed. Okay, so we can do an etiological classification of our brain vascular malformation. We understand now better the congenital nature of brain vascular malformation, but I think we can do more. Understanding the concepts of angiogenesis will help us to understand arteriovenous metameric syndromes, HHT, and certain other AVMs. For example, Van Hippel-Lindau disease can be very nicely explained by the cascade of HIF, VEGF, leaky vessels, angiogenesis. Because what is happening in VHL, you have the loss of the VHL suppressor protein, which will mean that you therefore have an accumulation of the previously suppressed product. And this happens to be hypoxia-inducible factor, which means that in patients with Van Hippel-Lindau disease, you have now upregulation of VEGF, and therefore you will have too many highly vascularized tumors. And these highly vascularized tumors have what type of vessels? They have very leaky vessels, which means that you will have significant enhancement in these tumors. And if you're looking at it from a histological point of view, you can see that these are immature blood vessels that are here related to the increased transcription of VEGF. Understanding this concept of migration at the head and neck region, where from the neural crest, your cells that form the pericytes and the adventitia migrate and they find the endothelial cells from the mesoderm to make the stable blood vessel, will help you to understand this disease called, in the French literature, bonnet de Chamblanc disease, or in the North American literature, Weber-Mason. Pierre liked to call it CAMS, or cerebrofacial arteriovenous metameric syndrome. And what is happening in these syndromes is that you have brain AVMs in association with AVMs of the face region. And these associations are quite specific. For example, you can have the association of a nose AVM with an AVM in the midline, in the corpus callosum, if your cerebrofacial metameric syndrome was that of the midline prosencephalon, where your cells that, let's say, have the propensity to develop an AVM migrate in a certain region to not only go towards the corpus callosum, but also towards the nose. And then you can have like these types of arteriovenous malformation, like this so-called Cyrano de Bergerac lesion, where you have a nose AVM, but in association also a corpus callosum AVM. So that's the midline or prosencephalic type. Which means for you, for your daily routine, if you have a patient who has a nose AVM, also inject the carotid arteries to look for corpus callosum AVM, and vice versa. If you have a corpus callosum AVM, check the facial arteries. CAMS2, or the lateral prosencephalic type, has involvement of the optic nerves, the parietal temporal occipital lobes, the thalamus of the maxilla. And again, you have a maxilla AVM, look at the brain, or you have a brain AVM, do inject your IMAX. The rhombencephalic type has involvement of the mandible together with the posterior fossa, petrous bone or pons. And we will talk obviously more about the arteriovenous metameric syndromes on a specific talk. This is just to showcase to you like where we can always kind of use this type of knowledge. Then I would like to briefly speak about HHT. HHT, as I said, has a problem of the angiogenic switch. You have missing either endocrine or ALK1. This will lead to pathological shunts. Now the group of the UCSF has identified that it's not only, however, ALK1 that needs to miss, or endocrine that needs to miss. An AVM here, there's the AVM in the mouse, only occurs if in association to ALK1 missing, you have the presence of VEGF. If there's only a defect in ALK1 and your VEGF levels are normal, no AVMs is forming. And of course, if ALK1 is present, then no AVMs are forming. So this indicates this two-hit theory. The first hit is the loss of ALK1. That was your primary hit. But then your secondary hit that makes the AVM to occur is that you have to have VEGF. And this allows us to now maybe treat in the future these types of HHT-related AVMs with avastin. And it does already work for the liver. It does not yet work for the brain because we do not know whether these AVMs can be regressive. But what we do know is that we can make knockout mice that form shunts that are either direct arteriovenous shunts or nidus type AVMs, and they have a striking resemblance with the shunts that we are seeing in HHT, the arteriovenous shunts or the nidus type small AVMs right here. These are human pictures, this is obviously the mice model. And this is work again from UCSF, that at least in the mouse model, the understanding that came from the initial experiments that you have to have a causative and a secondary trigger, or primary and a secondary trigger, you have to have ALK1 missing and VEGF, means that we can inhibit this secondary trigger. So here, avestin was injected, and you can see what happened with this AVM. The AVM regressed in the mouse model, okay? We are definitely not there yet in the human. So, this causative versus revealing trigger is an important concept when we try to understand HHT. And here are the examples that I wanted to show you with the new formation of arteriovenous malformations in HHT. This is an HHT patient that was screened at age 10, and it's a normal MR. I want you to focus on the left frontal lobe here. And you agree with me, there's nothing there, right? And this is the same patient at age 16. Right there is now a microAVM. You see here the abnormal blood vessel. There. And that's not there before. Or here's the T1 post initial, and 6 years later. There's clearly now a tangle of abnormal vessels right there, which was not present before. Or here, another patient at age 14, there's no abnormality in the left paramedian frontal lobe, but at age 17, there's a microAVM. So this just tells you that the remodeling of blood vessels can be helpful to make recommendations for screening for patients with HHT, for example. Then, understanding the concept of angiogenesis will help you to understand what is happening surrounding a brain AVM. If you have a brain AVM, especially those that have high flow, then distant to the AVM, there will be less blood flow going to the brain tissue, which will mean that the brain tissue surrounding an AVM can be hypoxemic. And what happens if tissue is hypoxemic? HIF, VEGF, immature, unstable vessel. These are your angry red vessels surrounding an AVM. And sometimes you can even see them. If you look at this tissue here, this is not AVM, this is not draining anywhere. These are like perinidal vasculogenic sprouting surrounding an AVM. And we will talk more about this also in the workshops. So, through surrounding an AVM, especially high flow AVM, you can have perinidal angiogenesis with a perinidal dilated capillary network. Look at this example. Does this patient with a MCA AVM also has supply from the ACA? No. What we are having here is induced to the shunt, induced by the shunt, induced by the hypoxemia. The leptomeningeal collaterals have taken over. You see the vessels getting smaller, 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 and then bigger, 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 and then go towards the AVM, hooking up to the MCA branches right there. So what we are seeing here is, due to the local hypoxemia surrounding an AVM, the formation of new leptomeningeal sprouts or leptomeningeal collaterals. Or think about your classical stroke patient that has an underlying high degree stenosis. These patients often have excellent collaterals. Why? Well, because of the high degree stenosis that was there, the brain is constantly hypoxemic, HIF, VEGF, collaterals, excellent collaterals. And so when I now see a patient who, let's say, comes to our hospital 8 hours or 12 hours into the stroke, has a huge perfusion deficit but relatively mild symptoms, I know that this patient must have somewhere a stenosis, either tandem occlusion on MCA stenosis, and I will treat this patient differently. I will not go in with a stent retriever, but I will first presumably just do aspiration, thinking that he may have an underlying high degree intracranial stenosis. Okay, so I do believe that understanding these concepts will help you to understand your diseases that you are facing, and it helps you to understand your complications. What do I mean with this? Here we have a cerebellar AVM fed by the ICA. There's the AVM nidus. And at this point in time, which is something which I would not do nowadays, we did try to do this from an endovascular approach. And we can see that the microcatheter stopped dead here. Not close enough, but we still try to embolize, and you can see that the glue stopped dead right here and did not go into the AVM. So what will happen with this patient? Well, initially the AVM is of course not filling because we've just ligated the blood vessel. But what will happen over time? The AVM is still there, right? Because we did not go into the nidus, we did not occlude the vein. But the brain tissue is now hypoxemic because we ligated the vessel. HIF, VEGF, new vessels will sprout, and lo and behold, after 6 months, there's the AVM. But now it's no longer filled by the ICA, but through like a network of abnormal vessels from the SCA, making it now way more difficult to treat. Okay, definitely impossible to treat from an endovascular point of view, indicating that sometimes maybe we should be a little bit believing more in the power of steel and neurosurgical excision, especially for brain AVMs. Then we do know that certain triggering factors can cause facial vascular malformations to really become bad. For example, if you have a ligation embolization for facial AVM, then this will lead to like sprouting of new blood vessels and to this AVM getting worse over time. So for example, in this patient here, with a huge bilateral mandibular AVM, the left imax was ligated, but this ligation will not do anything. In fact, you now see that all of these collaterals are still filling the AVM, and now you have made a treatable lesion untreatable. Okay, the last aspect that I wanted to discuss is on future treatments and how what we've understood can help maybe for future treatments. And here the seminal work of my colleague Ivan Radovanovic comes into play, where he found that not only HHT AVMs have abnormalities in their genes, but also sporadic AVMs. In fact, he found in a large number of patients that there were somatic mutations present, and these somatic mutations were present in the so-called KRAS pathway. And the KRAS pathway is a pathway that is of importance for cell turnover of the endothelial cells, cell migration, sprouting of cells, and formation of abnormal connections due to notch signaling. And this means that if you have a somatic mutation present in the KRAS pathway, you can develop brain AVMs. And this helps us now to understand that for certain AVMs, certain anti-angiogenic drugs may help. So if you are on the HHT pathway, you know you need VEGF, i.e. you can, with sirolimus or Avastin, treat those types of AVMs. However, the sporadic AVMs, they have a mutation in the KRAS and BRAF pathway, which can be inhibited downstream with MEK inhibitors such as trametinib. Okay, so I showed you this example where in the mouse model it already works that Avastin can lead to regression of AVMs. But now, this is really interesting work that is currently done. This is cutaneous AVM, where a biopsy identified that there was indeed a specific mutation in the KRAS, BRAF, and mitogen activated protein kinase pathway. And this biopsy then allowed the physicians to give a medication that immediately took out the one gene product that was over-accumulating, i.e. the MEK inhibitor. And these patients really led to regression of AVMs. Now, can we do this in the brain? Well, for sure it is more difficult to make a biopsy in the brain. So what we are doing is we are using liquid biopsies, i.e. where we go transvenous, where we take a blood sample and where we then look at microRNA signatures to identify whether a patient has a mutation in the BRAF KRAS pathway or not. So this is what we did in this untreatable AVM, juvenile AVM of the spine, or spinal arteriovenous metameric syndrome, where the patient was symptomatic, and I did not see any chance with radiosurgery, surgery, or embolization to cure the patient. What we did was we went transvenous, we did identify that the patient did have a mutation in the KRAS pathway, and we did now try to give the patient trametinib on a compassionate basis. Of course, this is not mainstream treatment, not at all. So this is like currently still highly experimental, and there are a lot of open questions there. There's the question, can these actually regress, or will they regress? Can we target other pathways? What are the side effects, in particular in the pediatric age group where we have growing body? What are the side effects when your normal vessels cannot turn over the way that they should do? So there are a lot of open questions, but I just believe that you as the next generation who will be out there should not only look at the obvious, but you have to look beyond the obvious. The obvious is the AVM and your onyx and your squid. And shall we use magic, or shall we use retrograde venous pressure cooker technique? This is one way. Like, you should start to think beyond only the treatment and beyond the obvious, and find that there may be other alternative management options for these challenging lesions. So, to conclude, and thank you for most of you to have stayed awake, understanding the concepts of vasculogenesis and angiogenesis allows us to have a, I think, deeper understanding in brain vascular malformation. Diseased vessels are not just pipes that need some plumbing, but they are complex biological systems that need treatment focused on the cause of the disease rather than the symptom. Thank you very much.